Mesenteric adenitis. It is a non-specific acute inflammation of the mesenteric lymph nodes. It usually affects the ileocecal region because of the abundance of the lymphatic tissue. So here the patient will complain of pain in the right lower quadrant of the abdomen. So we commonly mistake it as a acute appendicitis. It is a self-limiting disease and it is also a recurrent one occurring in children and young females. Coming to etiology of the mesenteric adenitis, it can be viral, bacterial, after an inflammatory bowel disease, and also seen in certain lymphomas. So there are two important gram-negative bacteria that are known to occur mesenteric adenitis are Yersinia enterocolitica and Yersinia pseudotuberculosis. Other than these Yersinia species, there are certain other organisms like Campylobacter, Mycobacterium tuberculosis, Salmonella, E. coli, and Streptococci. These organisms also may cause mesenteric adenitis. It is classified into two types. One is primary and secondary. In primary, as you all know, the cause is not known, that is unidentified inflammatory process. Whereas in secondary, it is due to some intra-abdominal inflammatory process, like in case of recent gastroenteritis, and also it may also occur after an attack of upper respiratory tract infections. Okay, there is even there are certain case reports, some case reports of mesenteric adenitis after an attack of coronavirus, like usually SARS-CoV-2. Okay, coming to pathophysiology, what happens here is the bacteria or virus, it is they are ingested orally. So they reach the gastrointestinal tract. From gastrointestinal tract, they invade the intestinal epithelium to reach the blood and also to Peyer's patches. From Peyer's patches, they spread through the lymphatics to reach the mesenteric lymph nodes, finally causing the mesenteric adenitis. Then what happens here? In mesenteric adenitis, the lymph nodes will be inflamed. That means they will be swollen, causing the capsule to stretch. What happens when there will be a capsular stretch? It causes pain. That is somatic pain. As I have already told you that the most common region is at ileocecal region. The patient will experience pain at right iliac fossa region. Okay. Coming to histopathology, assume this as a lymph node. First, there will be capsular edema and thickening. This is cortex, this is paracortex. At both regions, there will be increased plasma cells and immunoblasts. Okay, and this is the germinal center. There will be hyperplasia of germinal center. And also there will be lymphocytic aggregation at all these dilated sinusoids. Okay. Then even the lymph node is inflamed, that it is very red, right? But this lymph node, it won't get attached to either the peritoneum or the mesenteric leaves. Coming to clinical features, it commonly follows a recent attack of gastroenteritis or upper respiratory tract infections. There will be fever, vomitings, change in bowel habits, and pain at right lower quadrant or even at the periumbilical region, and tenderness. This is important because it is poorly localized, felt more deeply, that is on deep palpation. And one important point is shifting tenderness. What is it? Shifting tenderness is a tenderness that is not fixed to the right iliac fossa region, but when the child is moved from side to side, that tenderness will tend to shift. Okay, and this particular sign, it is mainly seen in mesenteric adenitis, but not seen in acute appendicitis. So, in acute appendicitis, the pain will be localized, and even on normal palpation, the patient will complain of pain. Okay, and this is not present. Like the pain, the tenderness will be localized, fixed to the right iliac fossa region in acute appendicitis. Okay, so these three are useful to differentiate mesenteric adenitis from acute appendicitis. Okay, coming to investigations. Lab investigations are complete blood count in which we have to look for the total counts. They will be elevated. They will be elevated on the first day of symptoms. Coming to the second day, they will again come to the normal. So you should not rule out the possibility of mesenteric adenitis even if the total counts are normal. CRP will be elevated and urine analysis to be done to rule out urinary tract infections. Then imaging, we do ultrasound abdomen because it is cost effective and easily available. There are two important points in ultrasound abdomen. That is, one is mesenteric lymph nodes will be enlarged and hypoechoic. And the second point is there is no thickened blind ending tubular structure. What does it imply? That means there is no inflamed appendix. Okay. According to the current radiological definition of mesenteric adenitis, it is defined as an abnormally enlarged lymph node of more than or equals to 8 mm in its short axis. Okay, and the lymph node enlargement and this kind of lymph node enlargement is also seen in acute appendicitis and also perforation, but they are less enlarged and numerous compared to the mesenteric adenitis. There is another advanced technology in imaging of mesenteric adenitis, that is SMI Doppler ultrasound, that is super microvascular imaging Doppler ultrasound. Mm, Normally, ultrasound, its parameter is size of the lymph node. Based on the size of the lymph node, it gives the diagnosis. But this SMI Doppler ultrasound, it takes into consideration the vascularity and gives the diagnosis. Even the color Doppler ultrasound also, uh, it is also based on vascularity, but it has been proved that SMI is better than color Doppler in assessing because it assesses both high velocity and low velocity blood flows and also better resolution, better image resolution. Okay, coming to treatment. Treatment, it is usually a self-limiting disease. So we give a supportive treatment. What is it? Hydration, either oral or IV hydration and proper pain control with the NSAIDs. We have to reassure the patient and also their family and bed rest. Okay. And it can be a viral and bacterial, right? So if it is a viral, it resolves spontaneously, but it can recur. Whereas if it is a bacterial mesenteric adenitis, it can be severe and the patient may need hospitalization and we may need to start the patient on empirical antibiotics. Okay, so what are the empirical antibiotics that we may use in this patient? Because the most common infection, most common organism that are responsible for mesenteric adenitis are Yersinia species. We have to go for either quatrimoxazole or third generation cephalosporins, fluoroquinolones, aminoglycosides, and doxycycline. Why? Because these antibiotics they broadly cover all the enteric pathogens. Coming to prognosis, The disease process may take around 4 weeks to completely resolve without any complications. So we have to reassure the patient and family regarding the length of the recovery period and tell them not to panic. And here the follow up is also very important. Take home message. So what happens here, coming to a correct diagnosis is very important in mesenteric adenitis. Why? Because it is very similar to acute appendicitis, right? Here you have to take a proper history, proper clinical examination, and also you have to make sure that the appendix is normal in normally visible and it is normal in radiological investigations, so that you don't confuse it with acute appendicitis and the patient won't end up in undergoing unwanted surgeries and won't suffer the morbidity. Okay, thank you.